This Week in Virology, the podcast about viruses, the kind that make you sick. From Microbe TV, this is TWiV, This Week in Virology, episode 655, recorded on August 19th, 2020. I'm Vincent Racaniello, and you're listening to the podcast all about viruses. Joining me today from Madison, New Jersey, Brianne Barker.
Hi, it's great to be here. It is 68 and cloudy here.
From Austin, Texas, Rich Condit.
86 and sunny, headed for 99. It was cool this morning. It was good. Cool being
no 100 degrees today, huh?
No, not quite.
From southeastern Michigan, Kathy Spindler.
Hi, everybody. It's 69 Fahrenheit, headed to 75, and that is 20 Celsius, headed to 24.
Chilly. Wow. I notice the weather is cooling slowly here at the end of August.
That's fine with me.
We have a guest today. He is a professor of Sociomedical Sciences at Columbia University Medical Center, which is where I have worked since 1982, and I've never seen him except on Zoom. He's Robert Fullilove. Welcome to TWiV.
Thank you. And I'm speaking from right across the street from the Columbia University Medical Center at 169th Street, where the temperature is 70 degrees and expected to get up to 78.
Wow. Unbelievable.
So
I'm not going to see that kind of stuff for a long time.
No. Did I pronounce your name properly? Fullilove?
Yep, that's right.
It's a great name, I have to tell you.
Et si tu parles français, c'est plein d'amour.
Plein d'amour. Ah.
Oui, say. C'est vrai.
The name is 1,000 years old. And it's something that right now in the United States has two branches. One, which comes from England, and the other, which is of African descent, which represents folk who were, how shall I say this, slaves to the original Fulliloves and who adopted their name. So, I can claim the new name, even though it has a heritage that goes far beyond the time that my ancestors have spent on this continent.
Can you trace the ancestry all the way back to a slave owner? Yes.
Just recently, my father and my grandfather, both of whom were physicians, and both of whom were very much involved in the practice of medicine in the 20th century, did keep records. And it turns out that the Fullilove family, the very large one, which has branches in England as well as in New Zealand and Australia, has kept a pretty interesting history. I think the whole point of who owned whom and at what date is some of what is at issue, because it appears as if there is really one Black Fullilove family, and there are a whole bunch of us, but we are descended from the same, forgive me, plantation.
Wow.
This takes us far afield from the topic of the day.
Oh, no, actually, it's not. I don't think.
No.
Not at all. So where was the plantation? Do you know?
As far as we know, Alabama. It appears as if my great-grandfather walked from Alabama to the Delta in Mississippi. My grandfather was born in 1982 in, I believe, Tupelo. Practiced medicine in Yazoo City, Mississippi, where he was the medical director of the Afro-American Sons and Daughters Hospital, which existed in that state at a moment when African Americans had no access to hospital care because of segregation, and served as one of the beacons of healthcare in that state for many, many, many years. So I was in Mississippi in 1964 as a field secretary for SNCC, the Student Nonviolent Coordinating Committee, as part of something called Freedom Summer. I spent a number of years in Mississippi engaged in voter registration campaigns and was part of the movement, if you will, in '64, which included the death of three of my colleagues, Goodman, Cheney, and Schwerner, who were killed on the very first day of Mississippi Freedom Summer at a moment when talking to African Americans about registering to vote was something in that state that might have gotten you killed. So, I have a long history of connection to both medicine on the one hand, but the fortunes of the state of Mississippi on the other. And the name neatly sort of brings up what the nature of that past is really all about.
So where were you raised?
I was born in New Orleans in 1944, so I'm approaching my 77th birthday, and raised in Newark, New Jersey, where my dad, a urologist, set up practice in 1948 because as a board-certified physician, one of the first 3 African Americans to be board-certified in urology in the 1940s, he discovered that the practice of medicine in New Jersey was going to yield many more possibilities than was the case in the state of Louisiana and in the city of New Orleans. So although I gladly trace my roots to New Orleans, I was raised in Newark.
Okay.
Nothing wrong with New Jersey.
Yeah.
Bless your heart.
I'm not too far. I am 20 minutes from Newark, right as I sit today here. I know Newark quite well. So tell us how you ended up being a professor in this particular field at Columbia.
Well, interestingly enough, I married Mindy Thompson Fullilove in 1983. Mindy is probably the leading African-American social psychiatrist in the U.S. at present. And in 1983, when we married in Berkeley, California, we were right at the beginning of what is now our recognition of the HIV/AIDS pandemic. She was on the faculty of psychiatry at the University of California, San Francisco, was asked in 1986 to head a research team that would look at the impact of HIV/AIDS on communities of color at that point in the history of the epidemic, when it was just beginning to become apparent that there were going to be outbreaks of HIV that would heavily impact, especially African Americans and Latinos. So, as someone with a doctorate in education, but a family history in medicine, and a lot of skill when it came to operating mainframe computers and using statistical packages like SAS and SPSS, she hired me away from the University of California, Berkeley to begin this work. And since 1986, we have really never looked back. We spent many, many, many years working in the HIV/AIDS field. In 2000, I co-chaired the Federal Advisory Committee to the Centers for Disease Control in HRSA on HIV and STD prevention and treatment. So for a 5-year period, at the culmination of my work in this field, I had with my committee, in principle, advisory capacity over the $32 billion a year that we spend on struggling with the issues that have been raised by HIV/AIDS. And now that we're in the midst of another viral pandemic, it's really interesting to see how much of a similarity there is between the struggles we had with HIV/AIDS and what I think is coming out as we examine more and more and more where COVID-19 has had its heaviest impact, and the ways in which that heavy impact has put a particular burden on poor communities of color in the United States. So it's sort of interesting that after almost 34 years, I'm kind of back in the same place, trying to make sense of a viral pandemic and why it's hitting the United States in quite the way it is impacting us at this day. It's been an interesting trip, to say the least.
How long have you been at Columbia?
Well, technically speaking, I started Union Theological Seminary in 1967. So that means, 53 years? I have a doctorate in education from Columbia Teachers College, where I have been teaching since 1990. And, have really started to think that if I were to be cut, I'd bleed Columbia blue.
So I want to trace your history before the doctorate, because I'm interested in sort of where you thought you were headed before you fell into HIV.
Yeah. In the 1960s, I thought I was a student revolutionary at a critical point in the civil rights movement. I stayed with SNCC up until 1967 and was part of what we just celebrated as the 53rd anniversary of a major community riot that occurred in that city that killed, 26 people. And that was part of a scenario of race riots in the United States that goes literally back to the turn of the century. So at that moment, I really thought that what I was doing was very heavily influenced by where I thought the civil rights movement was going. And then in my second year at Union Seminary on April 4th, 1968, Martin Luther King gets assassinated. My start in the movement was doing an internship in his office in the spring of 1964. So for a 3-year period while I was working in the South, I used to bump into Dr. King periodically. I even tried to get him to write me a letter to support my application to be admitted to Union Theological Seminary. But I kept thinking that I was not only going to be engaged in the civil rights movement, because I was interested in the church and the impact it was having at that moment in history to drive the civil rights agenda. When I entered Union, I really had this notion that I would continue that work as part of what I thought was going to be a much more expanded agenda for the civil rights movement that was going to include things like the Poor People's March, where you'd shift from race to look at issues of poverty. When Dr. King was assassinated, almost all that ended. And I think the only real lasting legacy of that period, interestingly enough, is bound up in the Kerner Commission report, which looked at urban riots in the US between 64 and 68, concluded with, in the prelude to its report, this notion we are rapidly becoming two nations, one black, one white, separate and unequal. And in a long report detailing the impact of racism on American society in the 1960s, it basically committed itself to demand that there be a larger federal investment in cities, a larger federal investment in dealing with poverty, and a substantial federal investment in education. There is one line that says the federal government should invest in promoting opportunities in higher education to assure that we become the diverse population that we are at this point in 2020. I believe that act to open up American colleges and universities with federal funding to support access on the part of students of color literally produced, amongst other things, the Black middle class, because the sudden entry of large numbers of people into post-secondary education did a lot to transform the relationship between, for example, social class, education, and positions in American society. So my notion that in the 1960s I'd be involved in the revolution as part of the civil rights movement emerged instead to becoming my part of the evolution of this country, when education, for the first 20 years of my professional life, was where I was trying to operate programs to assure that people had access to all the riches that American higher education has been in a position to provide. And that I'm still teaching, literally 56 years after teaching in the Freedom Schools in Holly Springs, Mississippi in 1964, is one of the ways in which I've sort of kept that particular dream about where I should be and what I should do alive.
Do you teach at Columbia the medical and the dental and the nursing students?
Yes, indeed. I teach, on average, 5 courses per week. But interestingly enough, the most interesting of the courses that I teach are in prisons. I've been a part of the Barred Prison Initiative for the last 10 years. That film that's available on Netflix, College Behind Bars, has brief snippets of me in the final chapter. But I've been very proud of the fact that having taught college courses in 6 New York State prisons has produced, amongst other things, 5 graduates of Columbia University's graduate education programs, 3 in public health and 2 in social work. They're all folk that I taught at facilities like Woodbourne State Correctional Facility in Sullivan County, New York, and Fishkill State Correctional Facility. I think of all the things that I've done as an educator, I'm most proud of that, because the graduates in public health have all gone on to hold very, very key positions in the New York City Department of Health and Mental Hygiene, and one is working at Montefiore, helping them figure out how to appropriately arrange the access to medical care that turned out, in the midst of their struggles with COVID-19, to be a pressing issue about who got tested, who got treated, who did well, who did not. And I'm really proud of the fact that as a guy who came from that community and did a substantial amount of time in prison, he's now back in the community making a serious contribution to what I'm hoping will be the evolution of public health and access to medical services in that borough of New York City. So I've had an interesting life as an educator, and I'm very pleased with where things sit at this moment, even if in the midst of this pandemic, it looks as if we're all going to hell in a handbasket.
So during the AIDS epidemic, you were involved in understanding, healthcare distribution to the underserved and et cetera. Do you feel like there were lessons learned from that progress was made that impacts on the current situation, or are we learning everything over again?
A little bit of both. Excellent question. My sense is that right now in public health in the United States, we've made an important shift from centering research on the characteristics of people who are ill or who are engaged in health risk behaviors to actually looking at the social circumstances that configure the set of choices that people have available to them. So under the rubric social determinants of health, we're now looking to not locate the problems of ill health in the individual. We're not thinking that the person is uniquely responsible for whatever his or her health condition might be. Now that we're aware of the fact that the environment contributes a substantial amount to the set of choices that people have available to them, if those choices result, for example, in an infection with COVID-19 or HIV, that we're looking at a broad set of circumstances that can be modified if we use public policy appropriately, is something that I think is a real move towards progress. We're not just looking for a pill. We're looking for other broader, more interdisciplinary understood solutions. And I think that's serious progress. One of the things that happened with HIV, the moment we got the capacity to really treat this disease effectively, it quickly became apparent that you didn't do very well with these medications if you were homeless, which is a real problem in New York City with a substantial concentration of HIV in that particular group of individuals. Having stable housing contributes so much to the prognosis of somebody who's living with HIV that for the first time we started to think that maybe there were things in the social and geographic environment that had to be a part of how we develop appropriate measures to assure that people had access to care and to make sure that the access they got actually resulted in a substantial improvement in their health conditions. I think that's been a real bit of progress, because the idea that it's got to be in the form of a vaccine or a pill is only going to take it but so far. My dad, for example, used to be proud of the fact, and said this just before he died as I started to do HIV work, "Son, beware of the cure." In 1936, when I was working with folk who were struggling with gonorrhea, the only thing I had was something in the way of palliative care. In the 1940s, I got a cure. I got penicillin. But son, I want you to understand, part of what has sent you and your brothers to prep school and college is the fact that I still treat gonorrhea, syphilis, and chlamydia. I've had cures for those things for many, many years, but the cure is not enough. If there are social drivers for these infections, then if you don't deal with the social element, curing the pathogen is never going to be enough. I think he was right.
Very interesting.
So would you say the problem is also about access to that cure and distribution to that cure?
Yeah. I mean, I think that's been the lesson we've learned with COVID-19. How many people were in poor communities that had to wait days in order to get tested, and then discovered that once the test was given, it was going to be a week or more before they got a result? Well, from a clinical standpoint, the doc needs that information right now. With the manner in which COVID appears to develop in the individual, waiting 6 days before you had a diagnosis, that's absolutely useless. So that there is now emerging a bunch of data that suggests where you lived and whether or not your county was one that was well off in terms of socioeconomic status, and whether or not your county was very poor, has a great deal to do with mapping the mortality that's associated with this particular virus. So you're absolutely right. Access to every element of what's necessary to treat a pandemic like this has a distinct and dramatic impact, not just on morbidity, but on mortality as well.
So what do you do with, in the case of, the example you mentioned, the homeless population in New York, where giving them an antiviral is not enough? And I assume it's because they're not in an environment where it's easy to take it and remember and so forth. So how do you deal with that?
Well, I think this has been one of the major struggles that folk like me have had as we've studied the course of that particular pandemic. NIH is much more interested in a pill than it is with sponsoring the revolution. They're not going to pay to deal with racism, which is a driving factor in so much of what we're talking about with both of these viral pandemics. I mean, if segregation in your residence is a major factor in whether or not you're exposed to this virus, again, whether it's HIV or whether or not it's COVID-19, then part of what you want to do is say, what can we do to limit the damage that's done by having such high degrees of racial segregation in the United States? That's something that at least is in principle possible with federal policy, but it's not something that NIH is ever going to get to. And as a consequence, one struggles to figure out how to actually put in place remedies that we know would work if only we had the political will to make them possible. I think that's always been the nature of the challenge. We've had the technology and the research for years and years and years and years. It's acting on it and feeling as if it's in the best interest of the nation. That has been, I think, the real challenge. And we haven't always met it.
One thing that seems maybe a little different with this pandemic is the concept of the essential workforce and how that might be playing into these disparities that maybe wasn't such a case with HIV.
Absolutely. I think you're absolutely correct. In other words, now that we see economically, forget public health, forget medicine. Now that we see economically, you cannot afford to have such an important component of the economy fall ill and become, for all intents and purposes, irrelevant to the economic fortunes of the nation. People are now saying, okay, what do we have to do to change that? And it is finally raising a set of questions that social scientists have been pointing to since Gunnar Myrdal. Once again, you're right. I think that the notion that you cannot leave a reservoir of infection untouched, something that we didn't learn with HIV because it's still with us today, but something that we're really seeing with COVID-19, might lead folks to sort of understand that just because you have contained a part of the population and made them an isolated element in, for example, urban society, doesn't mean that you've done all that is necessary to keep this particular virus from doing harm. Isolation is not necessarily containment. And now that we're beginning to see that, and now we're understanding that much of what we're talking about isn't just what happens to the workforce, it's the communities to which they return, where they're living in housing where large numbers of people can't do social distancing, where there may be 3 generations where young folk are in a position to infect old folks. I think this is causing us to raise a lot of questions, not so much because we care about those populations, but we care about us. And if they pose a threat to society as a whole, the idea that we have to do something for everybody is, I think, starting to take hold as a new approach to how we deal with issues of health disparities, that they're not just impacting those people. At some levels, they're impacting all of us.
So you mentioned previously differences between different counties and different areas in terms of morbidity. And I wonder how that might relate to other comorbidities and other healthcare issues that we see in different populations, and how that might relate to things like healthcare access. What types of things can we think about in terms of those disparities in other things like heart disease or respiratory issues that might be predisposing people to morbidity here?
Yeah, one of the things that I think is always instructive to look at is a report that came out from the New York City Department of Health and Mental Hygiene in 2004 that looked at health disparities in New York City. It's a bunch of maps. And at the end, you see that all the conditions that we associate with chronic diseases like diabetes, obesity, cardiovascular disease, what have you, they're all in the same places. And as you're hinting at with your question, We all know that those are also characteristics that, if you are exposed to COVID-19, are much more likely to result in, number one, hospitalization, as well as mortality. So yeah, that they're all in the same places is really important. And let's also look at the fact that we're in an era in the United States where we're increasingly aware of issues of race in terms of policing. In areas where you're going to have the highest police presence and the greatest likelihood that there are going to be dust-ups between the police on the one hand and community residents on the other, we're also talking about exactly the same communities. There is at Columbia University a project that goes back a couple of years that looks at something called $1 million blocks. This is a block in New York City, which, were you to go around and count all the folk who live on that block who are currently doing time in a prison in New York, and then multiply that number times $62,000, the amount of money we spend to keep an individual incarcerated per year in New York, you would come up with a whole bunch of blocks where we're spending $1 million, not on healthcare, not on education, not on housing, but keeping somebody locked up 200 miles from New York City. That those areas that have the heaviest concentration of $1 million blocks are also the areas that have high rates of health disparities, as well as high rates of COVID-19, means that at some level, almost all of the social fault lines that help describe life in urban America are being highlighted by COVID-19 infections because they're all in the same places. And it becomes real clear that to operate at any level of healthcare is also going to bring you face to face with all of the social conditions that are in these areas that not only push people much more in the direction of illness than in health, but which also account for some of the biggest problems we have with folk gaining access to appropriate levels of healthcare or appropriate levels of preventive health services. I mean, they're all part of the same thing. A food desert that contributes heavily to obesity and eventually diabetes and cardiovascular disease is also in a neighborhood that has a heavy police presence and large numbers of people being arrested and doing time in a prison somewhere away from the community. It is interesting to see how all this comes together under the same tent and how much public policy is actually going to have to address this if, as a nation, we're free of the ravages of something like COVID-19.
So you mentioned earlier that to address this is going to, at least one component is going to be federal assistance. And you mentioned that NIH either can't or won't be involved in that. So are there existing federal agencies that are appropriate for this, or do we have to think about restructuring the assistance from the top down?
I do believe that that's where we are, that we have to think about restructuring. And I believe that's starting to happen. I do a class on Monday and Tuesday evenings where I've got a whole bunch of folk who are here at the medical center who are interested in exactly these issues. And in talking about COVID-19, someone did a search that points out that there are a substantial number of new initiatives in NIH that specifically target COVID-19 and its impact on minority communities. So I am believing that there's some awareness of this at the top, that this is going to occur. And I guess since we haven't completely addressed the elephant in the room, wink, 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 who's in office in November is going to have a lot to do with how much is going to be put behind these kinds of efforts. And, you know, I think it doesn't take much to figure out how to handicap this particular race, especially when it comes to this set of issues. But yes, I think you're absolutely right. We are talking about a restructuring, but we've done that in the past. HIV, when it showed up, actually occasioned that kind of redirection, not just with NIAID, the National Institutes of Allergy and Infectious Diseases, but a whole bunch of the programs within NIH, including NIDA. When it became clear that drug use, the sharing of injection equipment was something that was driving the epidemic, there were a substantial number of initiatives that NIDA put out that specifically looked at what do we do about this and its connection to HIV. So we have the capacity and have done it in the past. It's really going to be a question of what's the leadership at the top going to look like? And will they see this as the priority that those of us on this broadcast see as, you know, something we've absolutely got to do? It'll be
So you've convinced me that you ought to head the new federal department that's going to take care of all this. Okay. What are your priorities? How are you going to do it?
well, to make sure that everybody on this broadcast gets a piece, because you've given me a platform, a bully pulpit, to sort of say this is what I think ought to be done. So I think that's what happens in government. Trust me, I was a grants officer within the Federal Department of Education from 1978 to 1983, and I do know something about how grant initiatives operate under the federal umbrella. So it is really true that typically what happens is there are ways in which you get the National Academies of Science to say, yes, NIH, you need to redesign everything that you do and the way you do it. You give them 18 months to produce a study. They come up with recommendations, and then you follow what they do. Do recall that in 1988, the same thing was done to literally revolutionize the way in which public health was taught in schools of public health, in ways in which the public health workforce was identified as something that was separate and apart from nursing and medicine, and established it as its own thing. So I know that, once again, being a guy who's old enough to recall history, that we have had successful efforts like this, that in the face of new challenges say, okay, let's reorganize the way in which we in government approach the solution of problems that are obviously pressing on the American people. And I know, once again, with appropriate leadership at the top, great things can be accomplished, because there are lots of people with great ideas who are really clear. Give me the call. I'll tell you what to do and how to do it. Richard, wouldn't you be one of them? Come on.
Sure.
Yeah, I'm all over it. Okay. I'm ready to go.
I rest my case.
I'm impressed by your optimism, because when you started talking today, I just said there's, in this current administration, how are we ever going to get any of these problems addressed? But you're assuring us that there are people around who are very interested in solving these problems, and we can do that, especially if we have a... Sorry, go ahead.
No, you're absolutely right. Well, let me tell you about my optimism. I remember in 1964 being in Walls, Mississippi. I don't even know whether it still exists. I'm in a shack that is owned by a sharecropper and his family. And I'm trying to get this person to think that, I know you haven't been to school, but you are a citizen in a democracy and you have a right to vote. And then I'm trying to really be convincing. And I turn around and point to a young child, a young man, 4, maybe 5 years old. And I say, that young man there, he could be president of the United States. I didn't believe that, not for 1 minute, but I thought it sounded good at the moment. And then 2008 comes along, and what happens? Bang. I am very clear in my life, I have seen the impossible occur. And whatever else can be said about Obama's presidency, I don't care. That's not the point. Something that was thought of as literally beyond the realm of reason in the 1960s suddenly becomes a reality in my lifetime. And I got to believe that if there is a teleological principle that drives the universe, that we are moving towards something that looks like purposefulness, that some of what's meant to be is we would learn the lessons that this pandemic is teaching us, and we'd act accordingly. I want to believe that that's possible. Listen, that I'm on this broadcast with you guys indicates that I'm not alone in having this level of awareness. And if we multiply your numbers by a factor of how many, somewhere there is, I think, a very large contingent of folk in our field who are willing to say this is the right thing to do at the right time, and we will support it. I got to believe that that's going to be true.
I feel like there's something going on here, because I've always thought of myself as pretty open-minded and fair-minded, but I have to say that the current movement, the Black Lives Matter movement, has really given me a heightened consciousness of what's inside me and what's going on around me. I mean, I'm realizing things, in particular, sort of the depth of the depth and the origins of the structure structural racism that I was not fully aware of before. And I can't be alone in this. There's something going on.
I agree. And I think part of what we're looking at again would be considered the fruits of what happened post 1968 with the federal investment in higher education. There are a large number of young people who've been raised in higher education settings where the issues of national structure, of racism, and of segregation have been taught, have been challenged, and people are ready to say, okay, I see how this works. I think you expressed it quite eloquently. And now that they can look at what's going on with new eyes, they're also making it clear we're ready for some kind of change. And that has not been present in quite the same numbers as is the case now. And because even with all the negative publicity, all the gun deaths and what are going on, people are able to separate that from the much larger issues of how did we get to this point? And aren't there structures that we need to change, that we need to alter, that can produce a different set of outcomes? As long as folk are willing to hold on to that and will support efforts to do it, I think seeing radical change, once again, in whatever time I have left on the planet, I think is something that I'm going to be able to witness.
So as I listen to you talk, I sort of have gone back and forth between optimism and sort of wondering, oh my goodness, what can we do? How can we deal with all of these things? And so do you have any thoughts about sort of what both short-term and long-term could be done to help with some of these disparities? And I will admit that some of this comes from the fact that I teach undergrads. And so what should I be telling them to do?
Yeah. The big thing, teach history. Here's one of the questions I have established in my graduate classes, just to let people know, my students largely, I know more than you do. How many American presidents owned slaves? I believe more than anything else, we are a nation that does not teach history. The Southern Poverty Law Center in 2018 did a survey of high school students, largely seniors. It asked the question, what was the major cause of the American Civil War? Only 8% cited slavery. If you're teaching undergraduates, guaranteed they don't know much about what happened the day before they were born. That's all an abstraction. They've got a gazillion pieces of technology that will keep them tuned into what's going on right now. But that the present is the child of the past is something that folks don't appreciate, especially at that critical moment in the undergraduate years when they could be learning, for example, about the history of slavery in the United States. 245 years when the land of the free and the home of the brave held people in bondage. There are 3 articles in the Constitution at its signing, at its founding, that basically established slavery as part of the economic structure of the then developing United States. If people are aware of that, if they know a little bit of history, if they're able to look at the present by also looking at the elements and the events that got us here, I believe that that will create an awareness of how to look at contemporary settings and situations that would be both balanced, historically accurate, and would give folks the sense that there is stuff to be done and that they might just be the folk to do it. I think the big move to get young people to vote is a really important element in all this, because we take all the issues of living in a democratic republic for granted. And a lot of people would be perfectly happy with fascism. If it meant I have a job and that the trains run on time, they go, okay, I'm okay with that. But I think if there's going to be any hope that there is some power invested in the people governing themselves, they have to know the history of how we got here and have to, just thinking about my story about organizing in Mississippi and Obama, they have to believe that once again, as a nation, we do have the ability to move towards change, to embrace it, and as a consequence, maintain our status in the current position we occupy in the world and with the world's economies. I just believe that if they knew more about what happened before they got here, they'd be a lot better able to make sense of what's happening right now.
You know, that seems to be a problem in all fields, that no one looks back and heeds the words of Santayana, right? he who forgets history
Let's
is.
not learn the lessons of history is doomed to repeat.
Yeah.
Right.
I mean, it happens in science too. People come in and they're trained and they don't learn anything about what happened 10 years ago. And it's so instructive. So it's a chronic problem with humanity in general. And I don't know why that is. But I guess it's easier just to learn as you go forward. I wanted to give listeners a feeling for numbers. So let's do HIV/AIDS. So what's the extent of the social disparity in incidence of that disease?
Well, let's think about its origins and the fact that we became aware of it in 1981. Slowly but surely, we struggled to figure out what was the nature of the active pathogen that was creating AIDS. And when it was finally identified as HIV, it was after a period when we tried to make sense of what did Haitians, hemophiliacs, drug users, and gay men have in common. It was a great epidemiological puzzle. And it became very clear that once we identified the notion that what we were looking at was a behaviorally transmitted condition, we started to really focus on what are the elements of the behavior that we have to worry about. When we started doing this work, Mindy Fullilove and I, in 1986, African Americans were 27% of the population that was identified as having AIDS. By 1996, almost 50% of new infections were amongst African Americans. So we've seen a gradual evolution over time where the nature of the pandemic and the populations that it has impacted has changed. And right now, part of what we're looking at is the fact that despite the fact that we have highly effective medications that can give people what approximates a normal lifespan, we are still confronted with the fact that between 35,000 and 40,000 new cases of HIV are identified every year. And once again, the risk factors are the kinds of things that we have a very difficult time understanding and controlling in a population as diverse and as complex as the United States. So the most impacted groups appear to be gay men of color, and increasingly in white populations, folk who are exposed to HIV because of the nature of their drug use. You all might be aware of the fact that Governor Pence, during the time before he became the vice president, presided over a major outbreak in Scott County, Indiana, where you had a sudden huge increase. Maybe you guys have talked about this before. I see knowing nods on everybody's face. But
No, go for it.
You had a huge outbreak of HIV amongst drug-sharing networks in this county that was entirely Caucasian. No African Americans, no people of color at all involved, suggesting once again that our continued inability to control some of the behavioral risk factors that come from the environment, the presence of drugs that people inject together by sharing needles, the fact that still persist means that it's not, once again, enough to be on top of the medical treatment of the condition. If you're not able to control the social circumstances that provide people with an exposure to it, you will continue, in spite of the presence of the meds, you're going to continue to have something that looks like a very problematic infection that costs us a lot of money to control, especially since it's largely found in populations that don't have the money to really have the kinds of lifetime healthcare that's going to be necessary to be okay. So once again, we keep thinking about the fact that changing social conditions often create the kinds of risks that people will take when they're suddenly unemployed, have nothing to look forward to, and somebody says, well, you know, if you get high, you can forget all this. And discover that, bing, overnight, you have a completely new group of individuals who now become part of a risk population because their particular social and economic circumstances make them really highly vulnerable to all of the pressures that are present in many communities to engage in this kind of drug use as a way of getting away from it. Medicating poorly diagnosed and poorly treated mental health conditions has always been one of the substrates of drug use in the United States. That drug use can now take the form of infection with a fatal virus is one of the things that I think is so peculiar about the nature of modern life, that so much of what we do has all kinds of health outcomes that no one would have predicted, but which haunt us continually to this day. And I think, once again, noticing that these are social conditions means that the best prevention has got to be something where you limit the possibility that someone will choose to engage in the kinds of behavior that are going to expose them to this kind of pathogen. Change the nature of the poverty in the social environment, change a great deal about what people are in a position to do with their lives, and you will have done a great deal to limit the kinds of problems that are associated with an infection with a viral agent like HIV.
Seems to me that this is essential to teach to medical and nursing students who may think all you need is a pill, right?
Yeah, I'm fond of pointing out, for example, just think about the problem we've had in the United States with obesity. You're a physician, you have somebody who is presenting in your office, clearly morbidly obese and clearly suffering from all of the issues in the metabolic syndrome that we worry about. Cardiovascular disease, diabetic, in addition to struggling with really, really problematic levels of weight. So what do? You say, listen, we got to do a couple of things for you to make sure that you have a chance at life. You need to exercise more. And I'm going to give you a list of things that have to be in your diet so that all the things that are killing you, all the fast foods, will no longer be a part of what's contributing to your obesity. The patient comes away, comes back in a month, and now has actually gained 10 pounds. The physician is like, oh my God, this person is impossible. What got ignored? Well, number one, this person lives in a food desert. There isn't any place in her community where you can buy the things that are on the list of ingredients that the doctor says have to be a part of the diet. In order to get that, she's got to spend way more money than she has. And she has to travel some distance out of her community to get access to places where that sort of food is provided. She's not going to do very much in the way of exercising. She should walk. It is one of the most important ways in which people can maintain appropriate levels of physical activity. But she lives in a community that is surrounded by gang activity. Nobody in his or her right mind goes walking by themselves through all the territories where people are constantly at each other's throats. So yes, she would love to exercise, but where she is, the nature of the social environment she's a part of, literally won't make that possible. This is not a person who needs to be educated about diet and about exercise. She's already clear about that. What we haven't addressed as physicians is what's the nature of the circumstances in your neighborhood? I'm giving you some things to do. Will it be possible for you to do them? And if not, what can we come up with together that will allow you to get the diet that you need and allow you to have access to some place where you'll do the exercise that I know is going to have a significant impact on your health? That's, I think, what's missing. The doctor made the correct diagnosis and made the correct notions present in the prescription that was provided. It's just that because it didn't have any awareness of the social circumstances, it was the best advice to the wrong person at the wrong time. Figuring out how to align all of those things is a part of what I think changes in medical education, as you suggested, is going to have to really result in, where we pay as much attention to where do you live and who are you around as we do with how you feel.
So I presented some of the data that you mentioned about differences in HIV rates in different populations to students in one of my classes. And a lot of my students of color looked at me and said, why did no one tell me this before? This is terrible. And so how do we actually increase awareness of some of these issues beyond sort of people who are actively studying these problems?
So that's my question as well. I've been at it for a million years, and yeah, it just kills me. Part of what I have been associated with is an effort to deal with churches in minority communities. Because with HIV/AIDS, they're often a part of the problem. They see this as evidence of sinful behavior. You cannot have a conversation in many church settings, many synagogue or mosque settings where you talk about homosexuality. Good luck having the preacher say something about drug use. And the old slogan from the 1980s, silence is death, is really true. I point out all the time to ministers, look, what we don't talk about is really driving this epidemic. And I would use your example, Jan. Yes, because people don't know that it is still with us, because they aren't aware of the fact that the all clear has not sounded. It is an ever-present danger that we have to recognize is part of what the community should be talking about. To my knowledge, in the Black and Latin communities in the United States, there are very, very few places where you're going to have open discussions about risk for HIV and what we have to do to protect ourselves and our kids. It is such a taboo topic that you can lose your job if you raise it at an inopportune moment from the pulpit on a Sunday, and you're a part of a church where the church pays your salary. They don't like what you say. They don't like the cut of your jib, and all of a sudden you're gone. So again, I am absolutely about the critical nature of education, but directed especially at people who are at the beginning of their experimentation with their sexual identities as well as their sexual behavior. I think those are really critical. And a lot of schools aren't that happy with the notion that, you got to have a demonstration of how to use a condom that uses something other than a banana. I'm somebody who does a lot of work in France. I've always been amazed at how much what we consider to be unimaginable in the classroom is something that is routine for them. I do know that it's possible. I do know that a reasonably well-educated youth population, where a substantial portion of our STD numbers reside, as you know, the more we can do to make them aware at a moment when we have them. Forget COVID-19 and Zoom teaching. When they're a captive audience, it seems this is really the moment where we get to say, y'all should be thinking about this. And some of the best programs I've seen at the university level have been led by students, have been real clear about how to use the language, how to raise the issues, and how to talk about these in a variety of different settings. And I do know that when they're well put together and when they're well maintained and run, all kinds of good things can happen. Once again, I tend to be optimistic because we have plenty of evidence of programs that have done very, very well. The issue is, how do we disseminate this? How do we make it more available? How do we make it part of the normal routine that in high schools as well as in institutions of higher education, this kind of instruction can go on? I mean, it is the challenge, but I do believe that with the evidence that we've gotten thus far, it can happen. You just have to figure out how to make it more widespread.
I find myself thinking about your experience in the prisons, because it seems to me that I'm imagining that the people that you encounter in prisons are there because of all of these circumstances in the communities. And while they are there for one reason or another, come to understand it differently. And you've said that some of these people return to the community, which strikes me as they would be, ideally positioned to do some good in the community. Can you give me examples of the sorts of community activity that these individuals might do?
Absolutely. And it's almost as if you and I had a prior conversation, so I set you up. On the level of HIV, in at least 28 prisons in the state of New York, there's a program called PACE, Prisoners Concerned About AIDS, Counseling, and Education. I've done World AIDS Day commemorations in 3 of these prisons for the last 5 years, and I am amazed. I typically will see an audience of between 200 and 250 incarcerated persons, all gathered to spend a considerable amount of time talking about HIV. You might be aware of the fact that the heaviest concentration of HIV, as is the case with COVID-19, is in our prisons. It's the war on drugs that put so many people there as a consequence. But for a long period of time, New York State prisons held 25% of all the inmates in the United States living with HIV. So as you can well imagine, everything about how do we care for this population, both in terms of their medical needs, and how do we care for them just in terms of the social circumstances that they're living with there. Well, PACE has been an absolute miracle. It is run by the folk who are in prison. It does a substantial amount of training with the help of the New York State Department of Health. It does an enormous amount to make sure that when people leave, they are aware of what they can do in the community if they're worried about, for example, resuming drug use and maybe being exposed to HIV. And here's the big thing. A very large number of people who work for AIDS service programs in New York City are folk who come out of PACE training that they got in prison. It is hugely impactful, doesn't cost very much money at all, and does an amazing job on the inside of having people deal with stigma associated with being a member of a sexual minority. In the one I saw at Fishkill, the gentleman who was head of the LGBTQ club in the prison spoke about the importance of HIV prevention. I was blown away by the fact that here's a highly stigmatized population that actually has a voice in this setting and is talking to a couple of hundred people. I mean, those are the kinds of things that lead me to believe that in settings and in circumstances like that, folk are not only making a contribution to what's happening on the inside, when they get out, they do very well. My 3 graduates from the Mailman School of Public Health, 2 of which work for the New York City Department of Health and Mental Hygiene, are all involved in some of the programs created to promote health equity. And they're very interested in making sure that people who are formerly incarcerated have access to appropriate health care services. Large numbers of folk are really worried about the fact that the moment they identify themselves as formerly incarcerated, everybody in the treatment setting is going to look at them as a pariah, one of them. That they're working very hard to make sure that there's a two-way street. Treatment centers learn about what it is to treat formerly incarcerated persons and learn something about the appropriate logic, the appropriate level of communication that has to be present in order for that to exist. And on the other hand, working with folk who are in the community who are afraid of getting access to healthcare, but who are told, look, we've got places where we know your issues will be dealt with. You will not be the object of stigma. You can do very well. I mean, these are all examples that we're trying to write up. I wrote an editorial with 3 of the students I taught in prison who also got graduate degrees from the School of Public Health that appeared in the January issue of the American Journal of Public Health when they did a special supplement on mass incarceration and its impact on public health. And it's a good example of them writing about what they didn't see themselves gaining from public health courses on the inside and how it dramatically impacted the way in which they looked at themselves, their training and their careers at the moment that they got out. I'm really kind of proud of that because it has proven to be one of the most effective ways of giving folk the sense that this is not a dead-end group of individuals, that they still have the capacity to contribute to community life. And if given half a chance, they will. It's been quite a ride.
This seems to me, I'm learning about a different set of people that can be trusted messengers. Through a colleague in my department, Ovita Fuller, I've learned about the church being trusted messengers and how that's been used in intervention for HIV and so forth. But this population obviously can be trusted messengers as well.
The term that they use is credible messengers. And a couple of my guys who are now out and who work with justice-involved youth, which is a big term in New York, people who are 16 to 24, have been in trouble with the law, haven't yet found their way to a jail or a prison, but who are at risk of doing that. Having folk who've done considerable time in prison talk to that population has had a very dramatic impact on their outlook, and even something in the way of how that at-risk population values an education. Because look, not only did I survive prison, where you don't want to go, I got an education on the inside. You have the capacity to get an education now without having to go through all that. You should seize the opportunity. And, I think it's a message from them that works very well. Credible messenger indeed.
So in the circumstance that you just described, what's the setting where the people who have been incarcerated are talking to at-risk people? Are these community meetings, or is it some sort of rehab, or what?
All of the above. Good question. So first, the city of New York has a long history of trying to deal with the problems of youth who are struggling with issues of criminal activity. So there are programs that have been created like the Police Athletic League, PAL. I have folk who work in those settings. There are specific programs that are put together by each borough's district attorney's office that are specifically targeted towards, look, I'm not going to send you to jail. I see you have some promise, You got to do a couple of months working with this program. Talk to these people there and see if you can't put your life back together. That's the setting. And then there are the usual community-based organizations that have for a long time been engaged with issues of incarceration and what happens to people when they get out. The Fortune Society here in New York City goes back to the 1960s. A substantial number of folk who work on their staff are people who are formerly incarcerated. Their number 2 guy, Ronald Day, just completed a PhD in the City University of New York. I mean, there are all kinds of ways in which you're seeing an understanding that this population isn't forever lost, that there are so many things that could be done. I'm one of the people who points out to my guys on the inside, look, the terrible thing is some of the finest minds in the community aren't in the community. They're up here doing time with you guys. You have a responsibility to go back. And a substantial number, many of whom were arrested after doing something stupid at the age of 16 or 17, now that they're in their 40s can actually see that. And the whole notion, oh, Lord, I do not want to come back here, is more motivation than one might imagine to make something of whatever kind of education they've gotten on the inside. Once again, it's, at least for me, a cause for real optimism. You should see the film College Behind Bars. It is quite, I think, revealing as a way of understanding why one is literally authorized, justified in having a lot of faith in what an intervention like this can do for the lives of folk who are basically in the worst dead-end situation in the United States imaginable. It's really quite inspiring.
I'll look at it just to see you.
It's on Netflix. It's on Netflix. It's free. If you just Google College Behind Bar,
okay,
you go to PBS, and they'll have it available. So by all means, do.
Okay,
we can find a link and stick it in the show notes.
We will.
Even better. That would be great.
Robert, here on TWiV, we get a lot of email from listeners, and I have one that I think you might help us with. It's from Victoria. She writes, a friend of mine recently challenged me with an opinion about transmission that I can't quite reconcile. First, let me contextualize by saying we both wholeheartedly support the Black Lives Matter movement and protests. My friend says there was no increase in infection due to the Black Lives Matter protests. Not everyone was wearing a mask at these events, nor were individuals staying 6 feet apart. In his mind, this suggests that it's okay for people to be socializing outside without masks or a full 6 feet of distancing. Are there any studies investigating a connection between the protests and infection rates? Hasn't contact tracing produced examples of outdoor dinner parties and open-air raves that spread the virus? From your perspectives, what's the difference between protests and outdoor parties vis-a-vis SARS-CoV-2 transmission?
Yeah, I think it's an excellent question. And some of the stuff that I've looked at suggests that the kind of socializing that occurs at a wedding, a family reunion, or a picnic is very different than what you'll see when people are marching down the street and aren't necessarily interacting with each other in ways that promote that level of intimacy. So we're kind of clear that it's indoor settings that are problematic. If we are, in fact, talking about a virus that's transmitted through aerosols, then indoor settings where virus continually circulates, you guys have talked about this, I'm sure, ad nauseum, is clearly one of the foundations, one of the platforms for exposing people to the likelihood of infection. Outdoors, marching, moving around, shifting around, maybe yelling slogans into the air, but not necessarily with each other and not interacting in the way that I think occurs at a family picnic. I know when my family gets together, there's a lot of hugging, kissing, what have you, especially with the kids. I'm not at all surprised that a setting like that, even if it's outdoors, isn't just the transmission that comes about because of what happens indoors. It's that level of intimacy, that very close contact is very likely to facilitate transmission in ways that being outside does not. I have not seen anybody identify a cluster that was identified with or connected to what was happening with these demonstrations. But then, as we both know, as we all know rather, the problem with contact tracing is what? We're lucky if 35% actually agree to tell you where they've been and who they've been around. And I'm not really clear that people who are in the movement are going to say, oh, yeah, I got it from them. So I want to acknowledge that there is a little bit of bias in that data because one assumes that everybody's willing to talk. It's not really clear to me that that's the case.
Yeah.
But I do believe that, again, what the difference between outdoors and indoor events is really critical.
Yeah.
And the level of contact at an event. whether it's outdoors or indoors. Those are the two variables that I think are going to be shown to be the most important.
And if I'm not mistaken, it's clear that there have been outbreaks associated with parties and bar gatherings and so forth, right? And I think the risk
Funerals
is quite
and weddings.
Yeah, right. I mean, I was at a protest over a month ago in my little town, and everyone was staying 6 feet apart. We were in the park listening to talks, and everyone had a face mask on. I was impressed at the level of compliance. So I think people are pretty good about that, and they see this is important, so we're going to behave.
Yeah, I think it's also clear from a lot of the data that there are ideological roots to whether or not you do or do not wear a mask and follow the directives of people in public health. So I'm going to assume that anybody who's at Black Lives Matter is probably not a conservative Republican teetering on the verge of fascism. if anything, you're on the other end of the political spectrum.
Yeah.
So the likelihood that you think Fauci is not a criminal and you want to pay attention to what he has to say, I think is much more elevated in that population. It is in the case of some of the demonstrations I've seen elsewhere, where people are carrying guns, riding motorcycles. I mean, all the, are we clear, stereotypes that are out there in American life. I mean, it is one of those settings in which stereotypes do appear to identify the pockets of risk that are associated with an infection with this virus.
Yeah.
And associated with whether you wear a mask, practice social distancing, what have you.
That's so true.
Excellent.
So true. Great point. Anyone else have anything before we let Robert go?
I want to make sure that Robert doesn't have something up his sleeve that we haven't talked about, some important perspective or item that we haven't asked him about that he wants to leave us with.
Because otherwise I could talk to him for a few hours.
Yeah.
I feel like this is one of those conversations I have with colleagues where I don't have to do, this is what a virus is. So, I mean, we're all basically looking at the same sources, and I think we're all pretty clear. And all of your questions and comments, I think they've been absolutely appropriate. And you've asked me things about my past that I didn't think were necessarily going to be relevant for something like this, but which I very much enjoyed revealing because they do tell people who I am and why it is I've come to hold the kinds of notions and engage in the kinds of activities that are so much a part of my life. For that, I have to thank you. This has been quite excellent. I'm very grateful for the opportunity that you've given me.
We agree with you about the importance of history and knowing both the history of things in big picture, but also understanding the history of where people are coming from and what they're doing.
I really appreciate your enthusiasm, and I appreciate your optimism. That's
for sure.
Yep.
Important.
It's great.
Yeah. I think we have to agree that the problem with pessimism is it gives folks the sense that there's nothing to be done, and they become passive actors, if that's not a contradiction in terms. And I think the last thing we need at this moment in history is for a passive population. We've got to be clear that there are things we should be doing and things we should be pushing our leaders to do, which is why I think having conversations like this with a listening public, I can't begin to say how important that is in my own work and how much I want to salute you for hosting something like this. You guys are doing great work.
I have to say that I first met you at a Zoom conference put on by some Columbia students, 2 months ago, I think. And I didn't know you existed. And I said, I have to get this guy on TWiV. And then a few weeks ago, they were arranging the orientation for first-year medical students. And they said, who would be somebody really interesting to talk? And I said, Robert. And I think you ended up talking with them, right?
I did indeed. And it went very well. So thank you very much. I owe that to you as well.
Well, you have a new fan in me, and I'm sure all of us are fans.
Oh, yeah.
Me too.
I think you're doing great stuff. You are welcome here anytime. Whenever you have a message you want to spread, please give me an email, and you can come on and we can chat for sure.
And this question of disparities comes up all the time, and it doesn't hurt to we ought to actually keep a list of emails and questions that we struggle with. Okay. Because, it's not like one conversation is going to cure this.
Nope. No, but I think.
Okay, good. Listen, I'm honored. Have me back. I'd be glad to do
Okay,
this.
we
This
will.
is
Great.
wonderful.
Thanks.
Robert,
And I'll take you up on your invitation.
And when,
Thank you very much.
One day when we can see each other again, I'd love to meet you outside for a little chat.
Oh, dude, let's have lunch.
Sure.
Remember your thing.
Right.
I'd really enjoy that.
All right. Robert Fullilove, Columbia University. Thank you so much.
Thank you very much. Appreciate
Thank
it.
you.
Bye-bye.
Thank you.
That's really inspirational.
Yeah. Wow.
I'm telling you,
Really informative.
I was so depressed when he started, but his enthusiasm just, he's right. Yeah. No point in being pessimistic. But that's something we don't talk about ever, and I think it's key, and everyone needs to be aware of this stuff. And it's not the last.
You can't separate viruses from their effects
Nope.
on the population.
But this idea that you have to teach medical and nursing students not just to deal with the infection, but the roots, right? The social roots, and that's hard.
Yeah, his sort of thought experiment with the physician and the woman who was obese was really good.
Yes.
Really good.
Mm-hmm.
I could see where his teaching would be essential, right, at a medical school.
Yes.
Let's do a couple of brevia before we do some email. Hey, Kathy, did you notice last time we got through all the email on the document?
Yes. It's impressive. I think that's just because some hasn't been added into the document, but for whatever reasons it works.
I did, but now we're starting over with a fresh new batch. All right, first though, first thing that's interesting, over the weekend, the FDA issued an emergency use authorization to the Yale School of Public Health for SalivaDirect, a way of diagnosing SARS-CoV-2 infection using saliva. And that is something we talked about on TWiV 606. And it's still, I believe, a medRxiv preprint, which is nice because it's easy to spit in a container, and instead of doing a nasopharyngeal swab, which is invasive and many people say uncomfortable. So that's good. And if you remember, Dixon talked about doing one of these saliva tests. However, it is still needs to be processed. The saliva has to be extracted to remove the RNA. Then you have to do RT-PCR. So you need equipment. You need a laboratory. So it's not the MENA-ization of the diagnostic test. But
sorry, Vincent, go ahead.
But it is an improvement, I think, because of the sample collection. And, if you've seen these lines of cars waiting to get sampled, then people walking up and putting swabs in your nose, you don't have to do that anymore. You can do it yourself now. But I do think it's a good step in the right direction, but we're not there yet, obviously. Go ahead.
So, chapter and verse, I know 2 now saliva-based tests that have EUA approval, which is a redundancy. One is the Columbia test, right? That's been
Did that get an EUA? Yeah, they got an EUA.
Yep, that's got an EUA.
Okay.
As a matter of fact, that was on the 15th, so that's only 4 days old. Okay, so that got an EUA, and there's this one, and I think somewhere in this literature, maybe it's even in this FDA article about the EUA for SalivaDirect. It says that there are actually 4 saliva-based tests that have approval at this point. Now, reading the bioRxiv paper, my understanding is that this is not like a commercial product or anything.
Right.
This is a protocol.
Yeah, exactly.
That they've tested out with a number of different reagents. And they also put a fairly cheap price tag on it, somewhere between $1.50 and $5 or something like that. But that, if I read this correctly, is just the price tag for the materials that go into this, and doesn't count the labor that goes into assembling those materials into a kit that can be used, and then processing the stuff through the RT-PCR and et cetera. So this is an EUA for a protocol. All right. I'm not bashing it. I just want to make clear what this is.
Yeah. Actually, some of the people who are involved have been rather active on Twitter in terms of talking about the fact that this is a protocol, and they're willing to work with other labs for sort of comparison testing and subbing out different reagents and things like that. And so they are actually quite clear that it is a protocol and not some sort of kit.
So the closest thing that I'm aware of at this point to a commercially available, and I'd like to be corrected on this, but the closest that I'm aware of is the Columbia test that was licensed to Sorrento Therapeutics. Now that that's got an EUA, depending on their, how they intend to market this, I would hope that now or within a short period of time, one would be able to buy that. And my spies tell me that in bulk, that test could ultimately be as little as $15 a test, which is still pretty pricey, but cheaper than anything I've seen out there. And that's still, let me see, that's a lamp test, right? That's an isothermal amplification. I don't know if it's lamp, but it's an isothermal amplification with a colorimetric readout. So at least that is potentially point of care, right?
Yep.
Right. So this particular thing from Yale is very clearly for high complexity labs because it goes on into the RT-PCR. I had communication with an epidemiologist who understands that people want to adopt this saliva over the nasopharyngeal tests, but laments the fact that if there is surveillance going on of these samples, they're going to lose the ability to be doing surveillance for influenza at the same time. And they can get that with just the nasal swabs or the nasopharyngeal tests, but not with the saliva test. So just one other downside to the saliva. But
so relative to that, this, if you'll recall, several episodes ago, we had a letter from David Stakes. Who was affiliated with an organization called Angstrom Bio here in Austin.
Right.
And they're putting together a saliva-based test that ultimately, without going into detail, it's a molecular test. It involves looking at the nucleic acid. It would have to be done in a laboratory, their laboratory specifically. But relative to your point, Kathy, they envision ultimately multiplexing this thing so that you're doing the initial amplification with a number of different primer sets and could look at a number of different pathogens.
That'd be good. That would be very interesting. We also have an email from John Klinkenborg, a retired MD, which sheds some additional light on this. Thank you for your TWiV podcast. You have a small legion of followers here in Lander, Wyoming. These include physicians, nurse practitioners, and non-medical fans from the National Outdoor Leadership School. The Michael Mina episode was just fantastic. Everyone that listens got so excited about the possibilities of cheap, fast, lower sensitivity testing for infectivity. We wrote to our elected officials and have been eagerly waiting, hoping that the fact Dr. Fauci and the FDA are aware of Mina's counterintuitive approach will speed up delivery of a spit and read test. Yale's SalivaDirect is a step in the right direction, but will be too sensitive. Touted as cheap, it won't be unless the lab or hospital that runs this test is part of your organization. Schools will need an on-site spit test that is CLIA waived. Much faster, and it won't bring up as many HIPAA problems as a send-out. Plus, it will get the kids or workers back faster. Spit negative 2 consecutive days versus rigid 10-day isolation. Keep up the great work. Thank you, John. All right, the other Bravia is a paper just published in Nature Communications. A single dose of an adenovirus-vectored vaccine provides protection against SARS-CoV-2 challenge. And this comes from the Beijing Institute of Technology, the Harbin Veterinary Research Institute, and how many authors contributed equally? Shipo Wu, Gongshan Zhong, Xunjiang, and Li Shuai. And then the last author is Wei Chen. All right, so what's interesting here, this is an adenovirus type 5, replication defective, as we've talked about before, with a gene for SARS-CoV-2 spike, which they have used to immunize mice. And they have immunized them by two routes, intramuscular or intranasal routes. And they get various doses, and then they wait 10 weeks. They measure immune responses, and you get, with both routes, very nice antibody responses. They look at binding antibodies and neutralizing. But the thing I wanted to point out, they challenged them 10 weeks later. No virus detected in the lungs or turbinates in all the intranasal vaccinated group at 3 and 5 days post-infection by qPCR, quantitative PCR, and infectivity assays. And then, of course, the control animals that got vector were all infected. No virus detected in the lungs in all the intramuscular vaccinated groups, while all the IM control group animals' lungs were infected with so much. Virus was detected in the turbinates of some mice of the intramuscular group by PFU assays and qPCR. So basically, when you do the intranasal vaccination, you seem to protect the upper and lower tract, which is not the case with intramuscular. And they say infection prevented in the upper tract is more difficult than in the lower tract from the different protection via different vaccination modes in mice. So I thought that was interesting because, not a lot of the vaccines we've been talking about involve an intranasal immunization.
This is the only one I'm aware of.
Yeah.
It got me thinking of the ones we've talked about. Would they have to be virus vectored? Would they have to be adenovirus vectored? Adenovirus would be a particularly appropriate vector for this, right, Kathy? Because that's going to be something that you might expect to infect in an intranasal route.
Right. Being a
I don't know
respiratory
that all
virus.
the adenovirus serotypes. Do you know enough about AD26 to know if that would work as a vector in this circumstance?
I don't remember whether it's in the respiratory group, but I suspect that it is.
Or chimp adeno, for example. I mean, most of them are respiratory.
The vast majority seem to be respiratory, and then there are a couple of intestinal, and then there's the ones that cause keratoconjunctivitis or conjunctivitis.
And I wonder if anybody's ever tested the messenger RNA nanoparticles to see whether they could be taken up intranasally. I don't know. Maybe so.
Maybe.
It's not obvious.
There are all kinds of APCs in there, right, Brianne? They could take it up.
There are lots and lots of types of APCs. I also find it kind of interesting that in their immunological data for their T cells, they see pretty big differences in cytokine production from the group that got the intramuscular versus the intranasal vaccine. They're looking in the spleen, so it could be because they're looking in the spleen, but it is sort of interesting to see what kind of difference in response they're getting.
Could you qualify interesting for me?
Yes.
Sure. So in general, the mice who had an intramuscular injection were making larger amounts of T cells making cytokines in response. So that could indicate that the intramuscular is making a nice systemic immune response in the spleen. That might influence what's going on with protection. But it's possible that intranasal made beautiful cytokines if we looked for cytokines in the respiratory tract. Obviously, they don't do that here. Right. But this is sort of known, but it just was nice for me to see in black and white data again, that all routes of administration, all routes of vaccination are not equal.
Okay.
And so if you think about doing a mucosal vaccine, you are going to get a different response
Sure.
than if you do
For
an
sure.
intramuscular.
So if I remember,
Yeah, to me, the differences. Sorry,
it's okay.
I was going to say the differences in the T cell responses between the two routes of inoculation were much more striking than the differences that they claimed for the humoral responses.
Yep.
Yeah.
So remind me, so the Oxford chimp adeno vaccine was tested in non-human primates over in Rocky Mountain. And if I remember, this is an IM injection. It did not protect against upper tract replication, right? Only lower tract. Is that correct? Am I remembering?
I don't recall.
Don't recall. You guys
That
are
sounds right, but I'm not sure.
You guys are as equally amnesiac as I am, huh?
Vincent, my brain is full. Okay.
Oh, you have so many
Or
neurons.
as, I had a student who used to say, too many penguins on the iceberg. You can only get so many penguins on the iceberg.
Brain has
You
got a
try and
lot
put
of,
another one on, and one of them falls off.
your brain has a lot of capacity. I think that was the issue, and because if you don't, so we don't know what these vaccines do in people because they're just in phase 3 now. We're going to see, hopefully, but if you are immunized and you still shed, in theory, you could transmit. So this is an important aspect. I like this, and we'll see what happens. I don't know what state this vaccine is in. Does anyone know? Probably.
Well, this is at least we can say it's an adeno-5 vectored spike protein vaccine, which in terms of that general description, that's the same description for the vaccine that was made available for the military.
Right.
Is in phase 3 trials for the military.
Got it.
Whether it's exactly the same vaccine or not, I don't know.
Yeah, and I think that's an IM. I think that's IM administered there. So
Yes.
they're not doing any IN, but maybe they'll think about it here. Anyway, it's very interesting.
They mention a couple of caveats. One that we've talked about a lot in the past, which is the pre-existing immunity to adenovirus could reduce the efficacy of one of these vaccines.
Right.
But they point out that at least for mucosal administration of ad-vectored vaccines, they may not be affected as much by pre-existing immunity. And then they also talk about the complication of giving these kinds of vaccines being a problem for people who might have get asthma attacks.
Yeah.
But they also kind of are a little bit optimistic about that as well, but clearly say that these are things that are going to need to be monitored really carefully as they go forward. I just had one little pedantic thing since you've been mentioning it, Vincent. The title, single dose of an adenovirus-vectored vaccine provides protection, and it should be vaccine candidate.
That's right.
Provides protection.
Yes.
Good
True.
pickup. Very good.
I found the paper that you were mentioning
Yes.
about the Rocky Mountain
right.
ad study,
Brienne. Good.
and it is intramuscular.
Right, and they still shed upper tract after IM, right? Yeah. Okay. Good. The other thing I wanted to mention is that, of course, we don't know how long this protection would last after IN. In fact, Brienne, mucosal antibodies decline more quickly than serum, right? So that could be an issue,
They do.
right?
Yes.
All right. So we'll see.
Okay, so that's a good question. Is there any difference in the mechanism or durability of a memory response with a mucosal immune response? What happens? What happens after an immunization in a mucosal route?
OPV gives you good memory, oral polio vaccine, but that's a different mucosa.
Right. I think that there are quite a few immunologists who are currently trying to figure out those answers to those exact questions.
Okay.
Most of what we study with memory responses involves looking at the spleen, which is looking at systemic responses. And so I think that people need to figure out some of those in terms of looking for memory cells that home to the lung or things like that, which are underway.
So the only nasal mucosal vaccine I know of is the flu mist, right? So maybe that's been looked at for that. It would be good to see. I'm sure that people have looked into it, how durable it is and so forth. All right, some email. Bill Tramontano writes, thanks for the Jesuit plug on TWiV. Fauci is a double Jesuit. Regis High School followed by Holy Cross. Oh, we talked about this. I don't know how the Jesuit connection came up, but I said, Bill is a good friend of mine I've known for many years. He is a former provost of Brooklyn College, former acting president of Queens College, started out life as a biologist and taught for many years biology at Manhattan College. And thank you for the Jesuit.
Jesuit that came up in an email.
Somehow, yeah.
Yeah.
Kathy, can you take the next one?
Sure. Aaron writes, hello, TWiV team. Longtime listener, multiple times corresponder. I was listening to TWiV 654, where Daniel Griffin was doing his clinical updates of the week. He mentioned that his hospital network was buying many Abbott ID Now platforms and was in negotiations with the BD people for their rapid antigen tests, and that the technology already exists and to go forth and get them. I'm 100% on board with that plan. I teach at the local junior college and we start on August 24th. We are mostly remote this semester with some upper-level science labs still happening on campus, as well as some of our nursing program skills labs happening in person. Ever since the Michael Mina TWiV, I, like you, have been clamoring to get our testing for faculty, staff, and students who are going to be on campus this fall. In Tetris, we believe, testing, tracing, isolating. Herein lies the reality of our situation, though, and I suspect many others' situation as well. While we have in hand a CLIA waiver license, we can't get any testing platforms. We tried to buy Abbott ID Now systems, there are none to be had. We tried to buy the BD tests. And while the people at BD themselves were responsive, we can't get any of the distributors to even send us a response to our numerous inquiries. I was finally able to get someone from Quidel, a Sophia antigen test, to, quote, schedule a call for me, quote, but that won't happen until late this week. We even tried to buy RT-PCR machines on eBay, as I know Brienne was able to find an EliSpot machine on there from a previous TWiV. There were no RT-PCR machines on eBay either. In desperation, I even tried to contact the makers of the large and wildly expensive machines like the Cepheid Express platform. Nothing. Silence. I know BD currently has capability to manufacture only 2 million test kits per month, and I know they are ramping up. But in the meantime, it seems like there are no tests for little peons like us. Our testing turnaround at the commercial labs is still so long that it is worthless to send students and faculty there. Our cases continue to increase, and our county currently has only 2 adult ICU beds available. That is 2 adult ICU beds in the whole county. This whole experience fills me with dread for what is going to happen in our county as schools open for in-person instruction, which is being discussed even still. The bright spot in all this is that TWiV continues to be there as a center of science and conversation that doesn't just depress me. Perhaps when all this is said and done, I can come run some plaque assays in Vincent's lab or learn some of the advanced flow cytometry experiments in Brienne's lab. Stay grumpy. And Erin is an instructor in Modesto Junior College.
Whenever I hear,
so this is very interesting. I'm interested to hear her experience with trying to acquire these tests.
Yes, I thought this would be informative. It's not easy, but maybe
I think that it's important to hear the real.
Yeah.
Whenever I hear Modesto, I can't help thinking of. I think there used to be ads on TV for Gallo. Modesto, California.
Oh, yeah.
Remember?
Yeah, that's wine country.
It's a wine country. Brienne, can you take the next one?
Sure. Sanjita writes, good morning. As always, an excellent Sunday morning episode 654. My companion on my early morning walks in this Texas summer. As a pediatrician, I share my frustration with your listener on the school board, who talked about testing issues and school reopening. He is correct that not only is the FDA a hurdle, but most of the physician community is not on board with the changing paradigm on testing. Here is an update by the American Academy of Pediatrics from August 13th. Most CLIA-waived rapid tests have limited specificity and sensitivity and may require follow-up testing. In general, antigen rapid tests are not recommended for routine clinical care, although rapid tests may have utility for population-based surveillance. While I agree that rapid tests can be useful for surveillance and not diagnosis, but stating that these tests have limited sensitivity and specificity turns physicians and the public away. Also, the testing czar, Dr. Brett Giroir, has shut down calls for cheaper rapid tests, calling them catastrophic. He doesn't believe in expanding testing and feels that we are doing more than enough. I have written to our state governor and senators, but only got a standard reply without much substance. Despite these hurdles, I've referred a lot of colleagues and patients to Dr. Minna's work and hope the public pressure and experts will help push the FDA or CDC to accept these cheap rapid tests and distribute them widely. FDA will probably not do that. Thank you again for being excellent teachers and scientists in this pandemic of misinformation. And Sanjita is an MD, as she mentioned earlier.
So we've had two town halls by the president and the provost, and we got a long letter as faculty yesterday. And the doubt and about the rapid testing is really frustrating. And there's this concern that there's going to be way too many false positives and that's going to make us exceed our quarantine capabilities. And, instead they're going to rely on things like the app that we have now where you report your own symptoms. They may even be asking about fevers or something because we're no longer getting fever tested. But I look at it as if we could get these rapid tests and they're frequent enough that the false positives are going to shake out, because just like if somebody has a fever now, they get sent to employee health and checked out further. And so if they came up positive in one of these rapid tests, they could be checked out further. It just boggles the mind that there's so much resistance to this, and that there's. I haven't heard that much about these tests giving lots and lots of false positives, but that's one thing that I'm starting to hear more about.
Yeah, remember Mina didn't mention that at all. He didn't think that was an issue because they're less sensitive. That seems to me that you're not going to have false positives, right?
I would. That would be my conclusion. Plus, I agree with Kathy. As a screening procedure, you can follow up the positives with a real-time test if you want to. Okay, until you convince yourself that there's not a lot of false positives. I don't see where that's an issue.
Seems to me like the previous MD said, you do 2 in a row. If one day you're positive, you do it again. And then you see what happens, right? You get 2.
Right.
That's Mina's thing. He says it's so cheap, you can keep doing it day after day, so it doesn't really matter. But, the people, if Giroir says this, shutting down calls for cheaper, that's ridiculous. He shouldn't be the czar.
And this idea that if somebody gets a positive result that, they're going to go into this panic and it's going to be really stressful. Well, I know of somebody who started showing signs, had the fever and a dry cough and, until they could get the test and the test results. You're going to have some level of concern. But if you can get tested again rapidly and confirmed or denied, you don't have to, be quarantined for an entire 2 weeks or whatever until you can get some long-term, a test that takes a long time, like a PCR test with slow turnaround.
Yeah, it seems to me if you're a kid going to school in the morning, you're positive, you stay home that day and you check the next day. And if you're negative, well, if you're positive 2 days in a row, you stay home for 10 days. Yeah. Rich, can you take the next one?
I just want to be absolutely clear here that Brett Giroir is the United States Assistant Secretary for Health. Mm-hmm. Okay. And he's saying, if I understand this correctly, that we're doing enough testing.
Yep, that's what he's saying. Yeah, it's a big problem. It should not be political. It should be scientific based. Can you take the next one, Rich?
As soon as I get over this.
Yep. No problem. Take your time.
Richard writes, I got to read the greeting. Kia ora from New Zealand, TWiV stars. So Kia ora, that's a greeting, obviously.
Yeah.
It's a Kiwi greeting.
Yep.
Mm-hmm.
I hope that...
it's in the Maori language.
Okay.
We've had a bunch of people from New Zealand write that. Yeah.
I hope it's not politically incorrect to say Kiwi anymore.
No, actually, so on Twin, This Week in Neuroscience, Jason Shepard is from New Zealand. And we got a letter there with some words like kia ora and something at the end, right? And I said, do you know this language? He said, no, I'm not a proper Kiwi.
Okay. So he calls himself a Kiwi.
Yes.
All right. You guys are just awesome. Seriously, the shows are so informative and yet presented in a familiar, relaxed, and jovial manner, interspersed only rarely by some very humorous rack and yelling, and Dixon trying to shift the conversation towards fishing. My dog also loves you guys, albeit indirectly, by the fact that I walk her for the full duration of each edition, which are regularly 2+ hours. That's pretty good. We're good for your dog, too. As you're aware, we've recently had an outbreak here in the land of the long white cloud.
Aotearoa.
Aotearoa, New Zealand?
Aotearoa, which means New Zealand in the Maori language.
Oh, good, Kathy.
At the end, I've put a little YouTube video where the woman says Aotearoa about 50 times.
Okay.
So you learn how to
So you've been
pronounce it.
practicing. Good.
Yes.
After more than 3 months so we've had an outbreak after more than 3 months of no known community transmission, leading to a shutdown of the largest city, Auckland. Back in March, New Zealand went really hard and early with a full lockdown, level 4, including shutting the borders to all except citizens arriving back from overseas with a compulsory 2-week quarantine. I think New Zealand has fairly received global recognition for getting on top of SARS-CoV-2, along with a few others, but I think being an island literally in the middle of the ocean with a low-density population, less than 5 million, in an area larger than UK with its 65 million inhabitants, has played a significant role. I agree with that. On the face of it, high praise should be directed to the likes of Vietnam, with its 95 million inhabitants and 1,000-mile border with China, and only a handful of cases and not a single death. The most probable source of the recent outbreaks is from the quarantine of returning overseas citizens. Some determined investigative journalists here were highlighting the poor practices with the government quarantine system that forced the situation to be dramatically improved. There were instances of people 12 or 13 days into their 2-week lockdown able to mix freely with those just starting their quarantine period after arriving in the country. And plenty of people were released before the results of their testing was known or the tests were missed. I mean, really?
Wow.
Yep.
Things seem better now, but there are regular instances of people escaping the quarantine or others breaking into the quarantine facilities. He says, parenthetically, yeah, we have our fair share of idiots on this side of the Pacific. I think we are far from doing the best we could. Use of masks is encouraged but not compulsory, and the testing regime is well below par. Forget about Michael Mina's proposed approach and the rapid point-of-care testing that has been instigated as described by Daniel Griffin. Just doing a decent number of non-rapid PCR tests would be a good start. I have one question, and if I may, one suggestion/request for a future TWiV. Question. One of the TWiVs, I believe, described how a vaccine candidate must have a minimum efficacy of 50% to be approved/licensed by the FDA. Whilst perhaps not great at an individual clinical level, presumably that is the level considered necessary to achieve some degree of herd immunity if taken by most of the population, particularly if 10 or perhaps 20% of people have some level of short-term immunity following natural infection. But what if the early candidate vaccines are less than 50%? Like the MENA approach of testing accuracy, could a lower efficacy vaccine work? As Fauci said, don't let the perfect be the enemy of the good. If a vaccine with 30% efficacy could be available even a few months sooner than a better vaccine, why wouldn't this be adopted? I seem to recall from a TWiV or immune episode that taking one vaccine is unlikely to prevent you from taking a second better vaccine when it becomes available.
Can we stop
let's
here?
Stop
Yeah.
for a minute
Yeah.
for this. Yeah.
So the 50%, and if you remember, we asked Denise Esposito, and she said they just made a number that they wanted to target. It doesn't really have any particular biological significance. And, I think what's important is how you define efficacy as well, right? Preventing of disease or preventing infection. They're two different endpoints, and, preventing infection might be harder to achieve. But from my understanding, 30% is about what you get for placebo effect. So no, you don't want a 30% vaccine. Fauci recently said, I forgot where I heard him. He said he doesn't think we're going to get much more than 50% efficacy. I don't know why he said that.
I don't know where he's getting that number.
Yeah. But anyway.
Why he's thinking that. Maybe based on comparison with, this reminds me that I occasionally touched on the differences between vaccines for respiratory pathogens versus vaccines for systemic pathogens. Are there differences that we can point to?
Well,
is it more difficult to make an efficacious vaccine for a strictly respiratory pathogen than for one that has at least a systemic phase?
Well,
I don't know the answer.
So remember, we talked about this with Udell, and for some respiratory pathogens that have a viremic stage, like measles, you get really durable immunity.
Right.
But for the respiratory pathogens where it's just a local infection, you don't.
Yeah, like RSV or flu. So it could be that this is where Tony's getting his number, is comparing the, looking at the efficacy for vaccines for respiratory pathogens how many vaccines for respiratory pathogens, strictly respiratory pathogens, are there? There's flu. Is that it?
Adenovirus.
We got adenovirus. We got influenza. Let's see, strictly
There's
respiratory. Yeah.
Measles doesn't count. That's got a systemic phase.
No,
Chickenpox doesn't count. That's got a systemic phase.
Measles, mumps, rubella, respiratory acquired.
Yeah, the only other thing I could think of is not viral, in terms of something like pneumococcus.
So it could be that this 50% number comes from experience with the limited number of vaccines that we have that target strictly respiratory pathogens. Because RSV so far is a failure, right?
Yeah.
We don't have a vaccine for that one, and that's strictly a respiratory pathogen. This is a sticky problem.
Oh, you're right. I'm looking at a list of vaccines licensed in the U.S., and there are very few for respiratory pathogens.
And this ends up going back to Rich's question earlier about intranasal immunity and do we get good memory responses, and highlights the need for some sort of basic immunology research understanding these things.
I think maybe we ought to get a hardcore vaccine person to talk about all things vaccines, right?
Yeah.
Yeah.
All right. We'll work.
And in particular, I want to hear more about mucosal vaccines as well.
Okay. We'll do it.
I might know some people.
Really hardcore, though. Really hardcore.
Yeah.
Which meetings are good. Okay. Let me know.
Okay. The continuing on this letter from our Kiwi friend. Suggestion. I listened recently to back-to-back TWiV episodes dating from the first one on SARS-CoV-2, episodes 52 to 58, I think. It was fantastic to listen to your conversations spread over 6 months and how understanding of the virus and disease has developed in that time. I wondered if now, 6 months into this pandemic, would be a good time for the TWiV stars to contemplate how this pandemic has unraveled. What your thoughts were back in late January, early February, watching the number of cases rise in China and wondering if it would spread wider, how deadly it would be, IFR, infection fatality rate, and how transmissible, and how much of the world would be affected on the specific topics that have arisen: use of masks, rapid testing, reopening schools, all eggs in the spike basket, and so on. I'd love to hear your perspectives on how you thought this would play out and what have been the big moments along the way. Condense about 100 hours of TWiV into a few minutes. And what will be the next big shift? Widespread adoption of rapid testing, release of the first licensed vaccines, big surge in cases as schools reopen, all of the above. For me, there was the before TWiV 640 with Michael Minna and after. And that's from Richard, who is an engineering geologist in New Zealand. So
that's a good idea. We'll do it at some point. Yeah.
Yeah, I can tell you in a phrase that I've been wrong at every step of the way. And so there have been a lot of changes in my perception. This has been very educational, and we just been discussing that. I think we're going to go to school on this vaccination thing, right?
We're gonna, yeah. For me, as we were reading this, I thought about how in the past we've done end of the year episodes where we go through and highlight the top 10 or so stories of the year, and how hard it is to condense that down. And this is just so much more. I do think it would be interesting for me to go back and listen to this. And also, I think I have a recording of the first time I talked to my class in around January 15th and said, have you heard about this virus in China? And one person in the room raised their hand. And what I said then about this is whether I said is this will be something to watch or whatever. But it would be informative to go back and see how we were then.
Kathy, when we do the top 10 stories at the end of this year, are they all going to be SARS-CoV-2?
Well, some of us are lamenting that there's a lot of other cool virology happening that we're not getting to talk about.
Yeah, I understand. I think there's plenty of time in the rest of the year to do some. Yeah.
Well, when is the rest of the year going to start?
The rest of the year starts about a year from now, I think.
I think so.
Well, the thing
I
is,
have to say that
the thing is, I love getting guests on. It's very easy to get people now, and for me, I'm learning. Like the one today was fabulous, and we have guests on Friday. So, yeah, I know. I
no, this is a special time.
How about September 1, Kathy? We'll start September 1st. We'll start some other virus.
You could start a new podcast that's just, other viruses in virology. What you need is another podcast.
TWiV, This Week in Other Viruses.
Yes.
What were you going to say, Rich?
I was going to basically say the same thing you did. The guests, we have ranged outside of our traditional comfort zone into areas that are relevant and fascinating to me. How do you pronounce his name? Fullilove?
Yeah.
Mm-hmm. Yeah.
What a fascinating Fascinating man. Fascinating subject.
You'll have the link in the show notes. And just checking his bio, he has these very interesting global things that he's doing. He mentioned France, and they both have French names. But just really intriguing.
I didn't quite glue together his whole travel history. Okay, because Berkeley's in there.
Yes.
And then he's got his civil rights activity in the South. I kind of wanted to talk to him about that a little more because so he's experienced firsthand hardcore segregation in the South from the perspective of a black man. Okay.
Yeah. Totally. I could talk to him about that for a whole nother episode, just that, the history of all that.
Mm-hmm.
And so I'm embarrassed that I've never met the guy in all the years. And this is because I'm sitting in my lab in the building.
You met him now.
And I never wander out, and I'm honored to have him on the show. I think he's fabulous.
Mm-hmm.
Unbelievable.
I'd take him up on
but the
lunch
other
for
thing I
sure.
wanted to say is I don't have a problem with out of my field. All you have to do is be curious, and it all comes after that. Just think of things. Yeah, it's no problem. I wanted to say, though, that I just pulled up the stats for the downloads of the audio only. Can anyone guess what the top downloaded episode of all time on TWiV is?
I'm going to guess the Minna episode.
Michael Minna, 57,000 downloads, just audio, and there's another 40,000 on YouTube. So we're approaching 100 grand. And the top 10, Tony Fauci doesn't even show up in the top 10. I am amazed.
Is that right?
Wow.
I mean, I'm amazed. Yeah.
Well, but he's on a lot of different things. I mean, you could find YouTubes of Tony Fauci talking to 15, 20 different people.
He just did an interview with Matthew McConaughey recently, who's our local hero, McConaughey. And so there was an article that I really enjoyed saying that all the celebrities, when they talk to Fauci, they wear their glasses so that they can look intellectual.
Well, we'll get him back. How's that? In the fall, maybe when we get some vaccine results.
Sure.
I bet he would.
Great.
I bet he would come back, and maybe we could have more of you guys on that time. You can meet the rest of the crew. The next one is from Sam. Hi, TWiV team. The recent discussions of whether school children can transmit SARS-CoV-2 brought to mind this quote from Dr. Benjamin Spock, the pediatrician, not the Vulcan. Quote, "There are only two things a child will share willingly, communicable diseases and its mother's age." End quote. Keep up the good work. That is fabulous. This is true. Kids transmit diseases. How can a pediatrician write an op-ed in the New York Times saying they don't? I do not get it. Kathy, can you take the next one?
Sure. Barry writes, a 2-for-1 deal, a question and a limerick. And just to let you know, the question is within the limerick. New Zealand was virus-free. It came back suddenly. This thing came from bats. Could it now be in cats? Plausible hypothesis.
Is Barry who wrote Twivering with Excitement, or is it just easy?
Could be.
Because someone sent that in, the title of the last episode.
Yeah.
Right. Maybe it was Barry. But anyway, so his question is, could the virus now be in cats?
Well, cats get infected, but I doubt if that's the problem in New Zealand.
Yeah, our previous letter kind of seemed clear about what the problem was in New Zealand.
Oh boy, the description of the screw-ups in quarantine is amazing.
Yeah, it's incredible. You know, this is very interesting. First, we have a haiku coming up. We're gonna have to make a page of. What do you say? What is haiku, poems, limericks? What do you?
Just TWiV poetry.
Just all poetry. Yeah.
Sure.
I think a cool contest one day will be write a limerick or a haiku with a question embedded in it, like this one, right? That's pretty cool. We're going to have a bunch of textbooks to give away in the fall when the new Principles of Virology gets published. They give me a bunch. I don't need them all, so we'll give them away. That might be one. Brienne, you're next.
Katie writes, Dear TWiV, I am a non-scientist but loyal listener of TWiV since the onset of the pandemic. I enjoy the political impartiality of your podcast and the focus on a scientific, evidence-based approach to your discussions regarding COVID-19. I am also a high school teacher who will be imminently returning to school in a hybrid model. While I feel fortunate to be a Massachusetts resident, I wonder about the state's initial fall reopening guide as communicated by the Department of Elementary and Secondary Education. In their plan, they cite many studies that show that school children do not transmit COVID-19 and a return to school is a very low-risk activity. However, on your podcast, I've heard that schools are petri dishes for infectious diseases. Further, there are almost daily reports in the New York Times about schools being forced to close after mere days of reopening due to the positive tests of teachers and students for COVID-19, e.g. in Georgia or more recently at UNC. Additionally, many news outlets have reported studies that appear contradictory to those presented in the Massachusetts DSE guide from countries such as Israel and South Korea, and even Denmark. Studies that suggest transmission can occur in schools, and teenagers are likely able to transmit the virus as adults do. Can you weigh in on this from a purely risk-based perspective? How do I know if it's safe to return to the classroom? And how might I gauge the reliability of studies on this topic? Thank you, Katie.
That was a big sigh.
That was a big sigh.
Yeah. I think this is really, the question everywhere. I would agree with you that schools are likely going to be places where we're going to see transmission. And I think it's really problematic that your state says that that is not the case.
Where are these many studies that show that school children do not transmit COVID-19?
No, they don't.
I don't
exist.
think they exist.
No, there have been one or
Okay?
two.
And
no.
once again, I think people conflate or confuse the idea of children not getting as much symptomatic disease with not transmitting it.
That's right.
And we've done papers before that show that children cook up just as much, if not more, virus asymptomatically than adults. I don't think there are a lot of transmission studies, but there is no reason that I can tell not to believe that children and teenagers transmit virus just as effectively, if not more so, than adults. So this is nonsense. Nonsense.
We've done a paper or two where showing that kids shed virus from the upper tract, and if they shed, they're going to transmit. That's all there is to it. It's hard to do the transmission studies because schools have been closed and so forth. But I think you need to assume they do transmit. To say they don't and use that as an excuse for opening is wrong. I think if you have a certain level of infection in your community, you can open. But if it's over a certain number, maybe 1 or 2%, we're getting towards 2% here in New Jersey, right, Brienne? And now the governor's thinking of closing things back down again. Mm-hmm. And as we spoke with the people from UCLA last year, if you keep the population less than 50%, do some rotations, that's really the best way to mitigate outbreaks. But as they said, it has to be combined with testing. You have to know who's infected, because if someone shows up in the school infected, then you have to stop. You have to send them home and all the contacts.
That discussion with people from UCLA was just last week, not last year.
Say last year?
You did.
Wow. Yeah, it was last week.
Yep.
The test positivity rate in Texas now, as of today, is 11%.
Wow.
That's down from there's some counting issues here, because we had a big spike for a while up to 20%, but there's apparently we're a backlog of tests, so I don't know really quite exactly what to trust, but it's high. Okay, and a lot of the universities, colleges and universities are going back to school. I'll be interested to see how that plays out.
Rich, can you take the next one?
Let's see here. Kip and Lori.
Yep. Laura.
These are both PharmDs. One is a dentist, 2 frontline TWiV ambassadors / TWiV supporters from San Francisco. Quote, in reality, it's very difficult to find simple solutions to complicated problems, end quote, from the book Contagion. Bye for now. And they enclose a wonderful picture of themselves wearing masks and the new TWiV Masks Are Cool t-shirts. Very nice.
Look great.
Yeah.
Look great.
Yeah,
Very
they do
nice.
look good. I got
Those
to
are
get me
sharp
one of those.
t-shirts.
Yeah.
Aaron Eastern. Nancy writes, dear TWiV team, been a listener since April. Appreciate your thoughtful, critical, and compassionate discussions about understanding and living with viruses. Yeah. I hope you can provide guidance on an issue that is a topic of concern and debate among my hiking buddies. Although outdoor recreation organizations and groups have developed their own rules for conducting hikes, no carpooling to the trailhead, wearing masks, and keeping physically distance on the trail, there has been no specific state guidance as to correct hiking procedures. And so one sees a variety of behaviors when hiking. Some hikers and runners wear masks all the time. Some pull up a mask when approaching others. Some step aside to let others pass. And of course, there are hikers and runners who don't wear masks, don't try to distance themselves, and continue down the middle of the trail.
But even in non-COVID times, there are rude hikers.
Yeah.
So,
Yes. Now, I assume that since we are outdoors and contact is brief, that the risk of viral transmission is low, assuming that the oncoming hiker or runner does not cough or sneeze as they pass. However, because many trails are narrow, it is often impossible to distance oneself 6 feet from another hiker, or because no shoulder exists, impossible to step off the trail and give oneself a little more distance. So, perhaps the risk of viral transmission increases slightly if the oncoming hikers or runners are breathing heavily or talking loudly, or if you pass in close proximity to 30 or more people, which is often the case on some of the popular hiking trails. Does the risk increase? But again, perhaps not by very much. Is the value of masking and keeping physically distanced in these brief outdoor encounters less about transmission and more about the acknowledgement of a social contract? That is, by conducting oneself in a certain way, are you signaling your concern and consideration for others in the community? Or perhaps it is best to follow distancing and masking guidelines in all circumstances instead of relying on one's judgment as to when it is or is not appropriate to do so. I look forward to hearing your views. All right, so here's my view. That last point is perfect. You wear a mask and you show that you care about other people. And I do that all the time when I'm outside. And I think hiking, I would, if I hiked, and I would like to go hiking, but I don't, but I'd wear a mask. And I think, as you say, the risk is low because these are brief encounters. Now, if you're walking next to someone for 15 minutes or more and they're breathing heavily, that's a risk of infection and you should be wearing masks. But if you're just passing someone, I think the risk is very low, as you say. But I would wear masks myself just because there are these hikers who don't, right? What do you guys think?
I really like the sentence that it's best to follow distancing and masking guidelines in all circumstances instead of relying on one's judgment as to whether or not it is appropriate to do so. I agree that these are probably rather low risk situations, but I too wear my mask in sort of all situations and think that sort of getting into that practice is a good thing for people to do. I don't wear it in my car by myself, but that, that's otherwise, if I'm out of the house, I'm wearing my mask.
You guys have covered it all. Okay. And to me, my reaction to this letter is that Nancy is asking all the right questions and that seems to have a grip on the topic. And beyond that, she kind of knows what the risk factors are, and you got to kind of titrate those risk factors in your head. And when in doubt, put on a mask. I can say for my own behavior that, I don't go out much. I mean, when my wife and I take a nice long walk every morning and we do not wear our masks, but we see maybe 4 other people and people are very good about moving literally to the other side of the street.
Yeah,
okay, so we never get into each other's air.
I think if you're in a situation like that where you know there aren't going to be people around, but here there are people on the trails, right? And so,
right.
I agree.
Petter writes, "Hey, love the shows. Thank you so much for your sanity in a FUBAR world. One, I'm giddy about the potential of ultra-prevalent rapid testing to ultimately fully control SARS-CoV-2, possibly even globally, and before any vaccine is ready. I'm thinking it's so effective that it will save not only people's lives, but also tons of money for society and any organization that applies the strategy. So with frustrations mounting as government officials and even MDs and everyone else are taking a long time to wrap their heads around this concept, I propose pushing it on Wall Street and Silicon Valley. Imagine Apple or Google or Walmart or some other big and well-known name largely reopening their headquarters and resuming close to normal business by requiring daily testing of all employees. When this within a few weeks would prove effective, we'd have the proof of concept we need for everyone agreeing to the strategy. With everyone young and old having been repeatedly taught and getting used to practice much higher degree of workplace, school, public place hygiene, is it reasonable to hope that future seasonal viruses might infect fewer people? Might this, if an effect in the short term, eventually lead to lower population immunity and subsequent cases of disease on average being more severe because people's immune systems have fewer contacts with any group of pathogens? Sincerely, Petter, and Petter's from Norway. So I don't know if having some big entity push the rapid, cheap, frequent testing would be the way to go, but maybe. What do you guys think?
Well, to some extent, that experiment's being done in Illinois. Okay, because, and I'll be interested to see if they can actually pull this off. Because as we've discussed, University of Illinois and Champaign-Urbana, and I believe also Chicago, are setting up using their own molecular testing system and a saliva-based test, setting it up to test all students and staff twice a week. And it's a prerequisite for participating in university activities. And I would assume that they're also keeping track of, what happens as a result. So although it's not a high profile like industry or something like that, and it is a specialized setting because it's a university, nevertheless, we're going to get some of the kind of information that you're looking for out of those experiments.
I think this idea of, Apple, Google, Walmart, Amazon, they're huge. They're everywhere. This is brilliant. So actually, when I saw this yesterday, I knew someone at Google had invited me to do a webinar early on in this outbreak. And so I emailed him and I explained the MENA thing. And I said, you got to tell Sergey Brin about this and tell him to get on it. So he said, okay, I'll call you back. Let's plan it. So, if he says, I never heard of this before and nobody's talking about it, then that's just a way to get more people talking about it.
And they have the money to do it.
The thing is, Google's already said nobody comes to work until next year, summer. Right. So I don't know how much motivation, but they're good. I shouldn't say they're good. People say they're bad. But they may have.
I was just going to say, there's an article that someone pointed out to me in the Atlantic, August 14th. The first sentence is, Michael Minna is a professor of epidemiology at Harvard, where he studies the diagnostic testing of infectious diseases. So that's all of the Atlantic story that I've read so far. But I think this is getting out more in the popular press. And so, yeah.
It is.
With respect to the second question that Petter asks about, is it reasonable to hope that future seasonal viruses might infect fewer people? I only want to say two things. One is that early on, I wondered what this was going to do to influenza. I remember specifically mentioning that. And then also, there was a woman who's now a journalist, but also an MD, and she had an op-ed in the New York Times about how she and her family were in China during the SARS outbreak, SARS-1 that is, and how the kids did better hand washing and other kinds of hygiene things. And she said it was just remarkable. Nobody got sick with all the other stuff that kids always get sick with at school. So I think there is some evidence for that. And then with respect to the concern about whether this would lead to lower population immunity for other pathogens, I don't think that's a big concern, but we'll let Brianne maybe talk about it in more detail.
Yeah, I would agree that I don't think it's a big concern. While I think it might be nice that we may blunt the current flu season a little bit, I don't think that we're going to be ever in a situation where we are living in the absence of viruses and bacteria to the point where we would completely alter our immune systems in that sort of way. So I see no risk of major global changes to our immune system. But I would be happy if I don't get the flu this year.
I frankly, personally, really doubt if in the long run it's going to, once, 5 years from now, whether our behavior is going to be significantly changed either. People like to party and they like to, be intimate with each other. Okay. And, they forget about people have a short memory. Okay. As Fullilove was saying today, they don't have much of a perspective on history. It all goes away. Everybody's just looking at their immediate surroundings. So I think we'll return to our normal abnormal.
So here's the really key thing here. This at the beginning, he says, hey. So is it hey or heya? Because I've heard in Sweden they go, hey, hey.
Yeah, hey is in Sweden, hey is hi, and that's H-E-J, I think.
Oh, so this is something different. H-E-Y.
This is unless it's, yeah. Oh, well, that could be the Norwegian equivalent of the Swedish hey. Hi, hey in Swedish is hi, and goodbye is hey do.
What does it mean, though?
Well, are you looking it up?
I'm looking it up, but
A year ago today, I was in Norway.
Did you ever hear heya?
Probably, but
Okay.
I might not have heard it as anything different from just sounding like hey.
I'm sorry. Brianne?
Justin writes, just because you want to one day bump into someone with TWiV merch. And Justin sends a picture of the Masks Are Cool t-shirt and the Countering a Miasma of Anti-Think t-shirt and a mug and a new TWiV mask that I haven't seen before. All of his TWiV merch.
Yeah, I think I said last time I'd love to bump into someone someday wearing TWiV stuff. It's funny, at the Science March in D.C., this must have been 3 years ago now, right? The one where it actually happened there. The first one, I'm walking down towards the mall, and these two people have TWiV shirts on walking towards me. They recognized me. Actually,
That's
I think
great.
I pointed to them or something, but that was pretty cool.
That's
Thank
awesome.
you, Justin. Anyway, that's a new face mask I designed over at cafepress.com/TWiV.
I also noticed.
Go
Go ahead. No, finish. I'm about to ask.
Someone had said the black ones suck. One lady wrote in, she said, this is not your best work. And I said, well, it's not really my work. All I did was put a logo on, but she said it didn't fit. So I made one at Cafe Press, which is a different logo. It's bigger, blah. So I ordered one. It's coming. We'll see if it works. But thank you, Justin, for supporting us. Okay, Kathy, sorry.
I was just going to say, I also noticed on the site that there are buttons for the meme, mice lie, monkeys exaggerate, and ferrets are not people.
Yes, someone made that. Designed that for us. Yeah, he sent it and he said, "Why don't you make a button out of it?" So I did. Yeah, actually, a few people have bought it. Actually, I have to say, people are going nuts on TWiV merchandise in the last month. I don't know why, but people discovered it, and if I just look at my Gmail, like every 10 minutes, there's a new purchase at Cafe Press. It's great. I love it. It means we're going to bump into people.
That's great.
More and more. So thank you very much, Justin. All right, Rich.
By the way, TWiV merchandise, is there a mask that actually looks like Sharon's mask on the T-shirt?
No, I could do that. It'd be a little small, right?
Well, if you just chose them, had her design a mask that looks like the
with that
mask,
pattern.
not the whole head. Yeah.
Yeah, just the mask.
Yeah, sure, that'd be cool. I'll look into it.
Don writes, "Good afternoon, all. I am just an accountant trying to maneuver my way through daily life in a pandemic. My question is, how do people justify in their own minds that holding or attending a wedding/reception with well over 50 guests, or choosing not to mask up, or not adhering to any of the other common sense guidelines is okay?" You got me. "I know you are not all psychologists, but this way of thinking really has me scratching my head," not touching my face though. "We have had several large gatherings and other events in our rural county about an hour and a half west of Chicago, including graduation parties, weddings, funerals, and our confirmed case count since July 8th has exploded, but the events keep happening. I've talked with several parents of teenage kids who don't want to upset their kids or deny them of their freedom to do what kids that age do. That really makes my head itch. I started listening back in March and feel you have all done a great job explaining very complicated stuff to us lay people. A friend turned me onto your podcast, and I've been an avid listener since. I even took the liberty to contact my elected officials, local, state, and federal, including an email to the White House regarding Michael Mina's interview in TWiV 640 after listening to that podcast. Just think where we would have been if this idea had caught on in March. Unfortunately, I received nothing but canned responses from a few and nothing from others. Keep up the great work, Don." And Don is in Mendota, Illinois. You know, Don, you're right. We're not psychologists. And, you know, I don't get it.
I think part of it is political. I think part of it is people denying that it's a problem. I think part of it is people saying we want our rights and don't have to wear masks and we should be able to do what we want. Here in my town, you know, they're considering online school, and the parents are having a rally to object. They want their kids to go to school. So it's all a mix of things. But you're right. We're not psychologists or psychiatrists. And it's nothing new, I think. As Kathy said, we're just behaving the way we always have.
Actually, in terms of, you know, once again, Fullilove's thing, if you need to read history, I just finished the Great Pandemic, and all of the same issues were prevalent then. They had anti-mask rallies. The mayor of Philadelphia, against many, many warnings, threw a big U.S. savings bond parade for the effort, because the World War I effort, that thousands of people attended. Everybody told him not to do it, but he insisted on going ahead, and it precipitated a huge outbreak. So nothing's changed.
I was in the post office a few weeks ago with a mask, of course. The postal workers have masks, and there was a lady wearing a mask talking to the worker, and she said, "This has all happened before. Just Google 1918. You'll see." Wow. I didn't say anything to her. All right, one more. Tony writes, "Dear TWiV, do you think it's right to create SARS-CoV-2 piñatas? See photo. If so, what should come out of them when you hit it?" I think it's a great idea.
I think it's a great idea.
I love
Beautiful.
these.
Those are really nice.
I have 3 suggestions so far. You could have licorice sticks, red or black licorice.
Nice.
Another candy that I just discovered is called Chico sticks, and they're long sticks that are kind of like the inside of a Butterfinger. But my cousin was talking about them, and so I ordered some from Amazon. And then the third thing, if you wanted to sort of designate like different bases, if you thought about those Smarties candies, the tubes of the little discs of stuff, or Necco wafers, something like that. So those are my suggestions to
I think
kind of
licorice
remind you of the
is
RNA.
the spaghetti licorice, right? To be like
Yeah.
RNA. Ah, yes,
Yeah.
that's perfect because you can get those pretty long. I think they're like 3
Yeah.
feet long.
Yeah.
Perfect. What a great
That's
idea.
nice. You guys are much more creative than me because I was thinking masks.
Yeah, me too. Too.
But it does have to be candy, of course, right?
Yeah.
All right.
But those are beautiful.
They
They're
are.
beautiful. They're gorgeous. And
Maybe that's a
fine.
maybe that's a show image. You've been doing YouTube screenshots of us, but those piñatas are beautiful.
Yeah.
You know, as long as the kids swinging at it are wearing masks, right? Everybody,
Yeah.
adults, kids,
Mhm.
everything. All right. Kathy, do you have some picks of the week?
Yeah, I'm a diehard. I'm still trying to get us to do picks, and I'm just trying to scroll down to where they are. The first one is Edwards Compass Rose Overview. So I get 2 different things daily. One is called the Daily Overview. This was yesterday's. It's Edwards Air Force Base in California, and it's a compass rose with the compass points on it. It's 1.2 kilometers in diameter. It's just amazing. So you just have to link to the main page of Daily Images, and then this one is from yesterday, which is August 18th. So figure out whatever showing for what day you're looking at it and count back from there. The second one is today's astronomy picture of the day, and it's the sun rotating. There's a video of the multi-textured sun with the boiling stuff and everything. And then there's 6 versions in color beside it. And there's this gorgeous restful music playing. But the first one beside it has sunspots that kind of come into view as the sun rotates. And then the sunspots at the end, a month later, come into view, and they're different. And so you're supposed to notice that. Anyway, it's pretty cool.
Very cool.
Awesome.
I like it. All right, TWiV 655 show notes app are at microbe.tv/TWiV. Someone wrote the other day, where are the show notes in a comment on the website? Well, you're there. microbe.tv/TWiV. They're called show notes because they're links to articles and links to the full text of the letters. microbe.tv/TWiV. And if you want to send us a question, TWiV at microbe.tv. If you like what we do, consider supporting us. Microbe.tv/contribute. There's links there to the store where you can buy swag if you'd like. Today on TWiV, we have had Brianne Barker, who is at Drew University, and on Twitter, she is BioProf Barker. Thank you, Brianne.
Thanks. It was great to be here.
Kathy Spindler is at the University of Michigan in Ann Arbor. Thank you, Kathy.
Thanks. This is a lot of fun.
And Rich Condit is an emeritus professor, University of Florida, Gainesville, currently residing in Austin, Texas. Thank you, Rich.
Sure enough. Always a good time. I really enjoy this.
I'm Vincent Racaniello. You can find me at virology.blog. I'd like to thank the American Society for Virology and the American Society for Microbiology for their support of TWiV, and Ronald Jenkins for the music. This episode of TWiV was recorded, edited, and posted by me, Vincent Racaniello. You've been listening to This Week in Virology. Thanks for joining us. We'll be back next week. Another TWiV is viral.